comes to children and adolescents, the families really haven't been included. And there are lots of historical reasons for that. I can talk about them later if you want to write about it. What I want to talk about really now is what we can do, because we've heard a lot about the problems, but we can actually talk about the solutions. I'm going to give you some of our basic takeaway messages, which is that today our children and adolescents are really served either alone by a provider or in the context of their peers, but not in the context of families. So our aim, it's a huge one, and I hope I'm around long enough to finish it, is to shift the paradigm from the focus on serving our kids either alone or just exclusively through peer support to serving and supporting them across disciplines and systems of care, including all the out-of-home systems, in the context of their families. We've worked with families by now from all different ethnic backgrounds. We do our work actually in English, Spanish, and Chinese, and we also work outside the U.S. There are 14 groups in 14 countries that have been following us, and we've now worked in about 6 different countries, including, I just came back from China a couple of months ago working there with Shannon and some of my other buddies who got to come with me. One of the things we've found in our research is that we've shown what, of course, all of us knew, you know, especially those of us who've worked on this issue, that families have a compelling impact on their gay and transgender children's health and mental health. But in an information age, and you're really the, you know, you're the harbingers of all of this for our community. You work with technology, you work with information. You have to show it. So we've actually shown this empirically for the first time, and in fact, with our research, we're building an empirical foundation, like building a house. And so everything that we do is really based on research and on the lived experience of LGBT young people and their families. We haven't really made it up. We use a systems approach that works from family systems. And our aim is not to remove kids from their homes. It's to strengthen those families ethnically and religiously and socially diverse families, to keep their LGBT children and adolescents in the home, to really prevent all of these kinds of conditions that I think really most of them really aren't preventable. We're developing a whole new family model. I apologize if you can't see the bottom of the screen, but we're developing a research-based and evidence-based model of wellness, prevention, and care. And I stress wellness because everything we know about our adolescents is focused on risk. And even in terms of the research, we don't know a whole lot about wellness, resiliency, well-being, but our work is focused on that. And if we can get the resources that we need to continue doing this work, we can continue to publish our data. And a lot of that has to do about how do we promote wellness, how do we get our systems and institutions, once we've established empirically what wellness really is and how to promote the well-being of our children and adolescents, how do we then foster that in our custodial care systems, in our schools, in our social institutions. I'm actually going to start with this when I think I was talking with Karen this morning, and she said, why aren't we talking about HIV? And I said, well, I talk about HIV, we talk about HIV. We've actually established a link between specific high levels of risk for HIV and STD diagnoses with family rejection. But when the media reported on our findings, and our first big paper was published in Pediatrics in January of 2009, they never talked about HIV. They never talked about STDs. They talked about the mental health aspects. So is that an issue of discomfort with this, or is it being tired of talking about it? I don't really know, but one of the things that we've been able to do with this work is using a whole strategic intervention approach with families to have an impact on multiple kinds of systems and outcomes that are really, really serious, life-threatening, and even life-ending for our children and adolescents. And our research and our approach impacts all of these different kinds of outcomes. One of the things that has been talked about a little bit more in the media, I think probably because we've been talking about it now for about 10 years, but the average age of that first crush for kids, regardless of their sexual orientation, is about age 10. And in all the research in the 1990s, that average age of self-identifying as lesbian, gay, or bisexual was between 14 and 16. In our research with adolescents in the 2000s, we actually found that that average age of self-identifying is a little bit over age 13, and the families find out about, on average, a year later. This has absolute critical implications because we're looking at 3rd and 4th grade, we're looking at elementary school. We've had lots of kids in our research who've come out at 5 and 7 and 9 and 10, not only to themselves, but to their families. And if the families aren't prepared, if the schools aren't prepared, if the systems aren't prepared, which is the case, there can be some very serious outcomes. The Family Acceptance Project isn't just research, it's actually research to promote positive outcomes for LGBT children and adolescents in the context of their families. So, yes, it's research, but it also has a whole professional training component, these strategic family interventions, and a lot of public policy implications for this work, and also very, very important implications for how our service is delivered. One of the biggest challenges is that providers across systems of care are still serving our adolescents with really a 1970s model of separating that adolescent from the family, not asking about the family because the perception is that it's going to be really volatile. There's very little that can be done about it. Our research is really changing the frame. In fact, I didn't put this up in a slide, but we've actually developed a rapid risk assessment tool that in a matter of minutes, a pediatrician, a nurse, a school counselor can identify the level of family rejection and related risk for gay and transgender youth, and then immediately act to bring that family in for counseling support and education. When we did our study, and even today, this is the first comprehensive study of what happens in families when kids come out or are found out during adolescence. So it's the first study that looked at this from the perspective of the whole family, not just the adolescent. So we wanted to look at how do families adjust and adapt when kids come out, but most importantly, how do they actually express acceptance and rejection? So we did this study that for the first time, it's a mixed approach, and I'll explain that to you in a minute, but where we actually identified over 100 different ways that parents and caregivers express acceptance and rejection. Now in our work, we can show how each of those 106 behaviors affects health, mental health, and well-being in adulthood. And now you can begin to think about changing the frame, how families that love their children, they want them to have a good life, they want them to be accepted by others. We can now show them with empirical research that's university-based, that certain behaviors that they were engaging in that they thought were going to help their children are actually putting them at very, very serious risk. We use pictures, we work with families from all different literacy levels, we work with families who have no formal education skills, we work with pictures as well to tell this story. Just really quickly, Anne talked about surveys. Our work includes a lot of linked studies, but it also includes, I'd call it sort of anthropological type research, where we go into the communities, we go into the lived experiences of LGBT adolescents and their families. We constantly go back to families to have them tell us what this information means to them. So in this big study of LGBT adolescents and families that included families from farm worker communities, coastal villages, farms, urban, suburban communities, we actually did these extraordinary interviews of 2 to 4 hours each with each key family member. We have about 8,000 pages of transcripts that we've coded and transcribed and have enormous information about what could have helped this family, what could have helped prevent a young person from being forced out of their home, from being placed in juvenile probation, from running away. And had that information been available, we also spent a lot of time talking with families who rejected their children, even threw them out of the home, and we found out that that's not what they really wanted to happen. And had they been able to do something differently, they would have. But this requires a whole new intervention strategy, which in effect is what we're doing. We didn't have all the funding. We would have needed about $5 million, almost 10 years ago, to do this with all ethnic groups, because we have native language speakers and people from different cultural backgrounds engaged in doing this work. So we started with the 2 largest ethnic groups in California, white and Latino, and we've expanded with ethnically diverse families since that point. We actually have enormous amount of information because we take it back to families, we take it back to providers, we take it back to youth, and everything we do is really informed by their lived experiences. This actually shows you a few of the accepting behaviors and a few of the very specific rejecting behaviors. Actually, this one is one that a lot of people wouldn't think is important. Talking with your child about their LGBT identity, normalizing it, having it be part of dinner table conversation, just as you would about other experiences of another kid in the family. Advocating for that young person when they're discriminated against by others in the family, as well as in schools and in communities. And part of what we do is to teach and empower families how to do that. Welcoming your child's gay and transgender friends and partners to family events and activities. These are all behaviors supporting your kid's gender expression. They promote that young person's well-being, and they actually protect against risk, and now we've shown that. And the same is true for 51 rejecting behaviors. Preventing your child from learning about their identity is a very high-risk behavior. Actually, among the highest risk, it's in essence like taking the oxygen away from really learning who they are. But now that we can show parents that behaviors that they're doing because they think we're helping their children are actually hurting them, we're really shifting the frame. This shows you a little bit about what we found. This is suicidal thoughts in the past 6 months, and this really is rooted in a sense, I think, of hopelessness. So what you're seeing here are LGBT young adults who were raised in families that were not at all accepting of their identity, all the way over to extremely accepting, and about 60% of them from families that were not at all accepting were thinking of taking their own life in the last 6 months. But look at what happens with a little bit of change. And so then we enter the realm of harm reduction, which I think, we're very familiar with in other kinds of health-related issues that we deal with. We looked at breaking our sample up into those young people who experienced high, moderate, and low levels of rejection and acceptance, but I'm just showing you a little bit of this here. And what we found was that LGBT young adults who were highly rejected had a lot of those rejecting behaviors during adolescence. By the time they're young adults, they're about 3.5 times as likely to be at high risk for HIV, and that's cut in half with moderate levels of rejection. We saw the same thing with illegal drug use, a similar kind of pattern, more than 3 times as likely to use illegal drugs, and about cut in half with moderate rejection. And if we look at lifetime suicide attempts, you really see this impact of almost 8.5 times as likely to have tried to take their lives at least once with high levels of rejection, and the extraordinary drop with moderate levels of rejection. So now we enter the frame of what are we actually doing, and I'm going to skip, well, I'll show you this one. We looked at things like gender conformity or gender nonconformity and how that young person behaviorally expressed their gender, and we found that when their parents tried to force them to change their gender, they had very high levels of risk as a young adult. About 5 times as likely to report high levels of current depression, 3 times as likely, almost 4 times as likely to have tried to take their own lives or use illegal drugs, and at higher risk for HIV. These data in particular haven't been published, but I want to show you this. We haven't put this out yet, but what we've been able to do is to parse what represents high levels of risk. So of course we would agree that physically beating or hurting or verbally demeaning your child, you faggot, you this and that, is really going to put them at high risk. But we found that things like preventing them from having a gay friend, learning about their identity, participating in a GSA, excluding them from family events and activities because of who they are. These behaviors had the same impact as physically beating your child because of their identity. And together they had a 9 times greater likelihood of attempted suicide. And you can think about these behaviors as preventing your child from learning about who they are, as common behaviors in rejecting families, thinking that they're actually helping their child when in fact they're putting them at high risk. We've also looked at things like religious-based condemnation, and now for the first time we've identified different ways that families use religion to reject their children, as well as using religion to support their children, and we can then make that health link in young adulthood. We looked at the same kind of analysis with the supportive behaviors And you see some real parallels: supporting your child's gender expression, welcoming their gay and transgender friends and partners, believing that they can have a good life as a gay or transgender adult. These are among the most wellness promoting, along with those like advocacy. Advocating for your child is not only a kind of a good parenting act, but it actually promotes well-being and helps reduce risk. Supportive religious practices to support your child, all the way down to, for families that are really struggling with these issues, just talking with them, just sitting and listening and not berating them or punishing them, but creating a space to talk about these issues that really opens the door and helps create more connectedness in that family. So what we've done, and I apologize for taking you on a whirlwind tour, but didn't have much time today. Our research is actually showing for the first time that these specific family rejecting behaviors, which are very common, by the way, we've seen them around the world in other countries, both the rejecting behaviors and the accepting behaviors, that rejection is linked with serious health and mental health concerns in adulthood, and that acceptance is protective and also helps promote well-being. With our strategies, we're using basically 3 of them. So how many cooks are there in the room? How many of you like to cook? Quite a number of you. What we're creating is really a recipe book for healthy LGBT children. So that recipe book is ultimately going to include decision trees, protocols, guidelines, a step-by-step manual, if you will, so that a school counselor in Iowa, a pediatrician in Tuscaloosa, a foster care social worker in Sacramento, so that they can all use these different approaches, to help that family understand that much of what they understand about sexual orientation and gender identity is really based on myths, and that there are whole ways to help that child develop into a healthy, supportive adult. We also help families with communication skills. We're developing tools, assessment resources to help them measure the change in behavior of those rejecting behaviors that come very commonly, because this is what they hear from their family, from the community, maybe even from the pediatrician, from their clergy. We're helping them understand that those behaviors can really increase their child's risk. And peer support is absolutely incredibly important, and that's peer support that's indigenous, that's community-based, that really reflects the lived experiences, the cultural traditions, the ethnic background, the linguistic experiences of those families. So we're developing some new, I would call them indigenous models of peer support that can, at a very low cost, be put into communities around the U.S. to really help people come together around what's important to them: their children, their faith, their culture, and food. And it works. We're using a lot of different materials to tell this story, if you will. Our academic publications are really a foundation, an empirical foundation, but we're developing these really quite extraordinary, very short, real stories that show the journey from struggle to support of ethnically and religiously diverse families. These stories don't get told. And embedded in these stories, they're not just moving stories, embedded in them are these accepting and rejecting behaviors that we've measured. So these are actually intervention tools, they're public education tools, they're designed to give youth and families hope, because the messages that youth get can't come out to your family, it's not really going to be a good experience, they're not going to be able to grow and change. We've seen not only extraordinary diversity, but we've really worked now with hundreds of families over the last almost decade that I've worked on this project after we started it. And there is an extraordinary capacity of families to grow and change once they understand how to help their children. And we approach them in a very non-threatening, reinforcing way, building on the strengths. For example, we see their faith as a strength, or their cultural values as a strength. And so that's the reason why, for example, evangelical ministers will call me up and say, "Hey, Caitlin, will you be on the radio with us?" Or we're able to work with Mormon and LDS families and find that our work is very, very helpful and is really respected by those traditions. We've been developing family education materials. We just got funding from Contra Costa County to develop materials at 2 lower literacy levels, so then we'll actually have 3 all the way up from comic book level up to about a 9th grade level, which is a great span of materials. And we didn't make this up. This is our research. We took it back in pictures in different forms to families from all different kinds of backgrounds, and we did this in English, Spanish, and Chinese, and we said, hey, you know, what are the most important things that you've learned from our research for families like you? What should our materials look like? How should we tell these stories? And so that information that we're actually developing, we're being guided by families themselves. Community engagement is really, really important. We have to change the way that our communities see families. So many of them will use the term the enemy, and they'll actually see families as the enemy, or providers will talk about families as a can of worms. And obviously that kind of perception is experienced by families who have enormous trepidation about dealing with these issues in any different kind of forum. So our approach is a very supportive one, but obviously our aim is to help those families modify behaviors that are really going to put their kids at risk, and also to keep their kids in the home to strengthen the families, because once kids end up out of home, regardless if they have a neglectful, abusive, screwed up family, it's actually far worse for them to be out of the home than it is to be in a home that is dysfunctional. These are actually different components of what we're doing. Provider training is really the key. Using the media is a key. I know that a number of you have actually written about or blogged about some of our findings, but it's actually very hard for us to get our messages out because our messages are different ones than are typically being told in the community. And obviously we rely on groups like you to tell our stories, but also to bring messages of hope that our young people and these diverse families are not typically hearing. These are some of the findings that we have sort of sitting in a drawer, you know, waiting for additional funding so that we can get them out. We can actually show how do we promote positive LGBT adolescent coping that hasn't been published before. We can show the long-term impact of GSAs on health and well-being. We have a really important paper coming out in May that shows the long-term impact of anti-LGBT school victimization. We teach families how to help their LGBT children in schools, how to prevent victimization, and how to mobilize and respond when school victimization occurs. We can actually show the health impact of reparative therapy and the health impact of religious condemnation and support. There are enormous implications for public policy for our work, actually changing the way that our children and adolescents are served in all of the out-of-home systems, even changing the way that homes programs work with these young people, reframing services, changing the way that pediatricians work with our children across all of the disciplines. And once we understand what wellness really means, and that's coming out of our work, and how to engender that in our children, it totally changes the frame from only preventing them, you know, preventing these bad things from happening, to supporting positive, healthy, normative development, which is still something that really doesn't happen. So I'm bringing you back to these multiple outcomes. I want you to think about the question, why aren't we talking about families in the context of our LGBT children and adolescents? 3 times we've actually done statewide surveys here in California, one of the biggest states, I think probably anywhere. It's a really big one, and it has a lot of services. And what we found is that there are hardly any activities for families with LGBT children and adolescents. The services are really geared towards older folks or adults. But those diverse families with children and adolescents don't have a place to go to get their questions answered from other parents who are really going through these things, who, as one of the dads that we hear from will say in our video, he said, I just wanted to learn from another dad like me, somebody who was a little bit further down the line about how I could help my son and what I should be doing. So I guess that's one of the questions that I think would be really helpful to think about, because I feel like we've got a solution. And it's really, really hard, not only to get our message out, but also to fund our work. So could we actually show that, that video? One of the, I'm trying to create a whole series of videos